All right, well, good afternoon, everyone, and welcome to today's webinar in our Improving Access to Quality Medical Care webinar series. A couple people are still filtering in, but let's go through sort of our, the beginning routine in webinars. So I'm Elizabeth Krupinski. I am the Associate Director for the Evaluation for the Arizona Telemedicine Program. And today's webinar in specific is brought to you by the Arizona Telemedicine Program, the Maricopa County Medical Society, and the Arizona Department of Health Services. Next slide. I would like to extend a very special welcome to everybody who joined today's webinar, especially everybody who is an Arizona healthcare professional, and we thank everyone for their service. And our other partners and colleagues in Arizona and throughout the Southwest, since we do broadcast this webinar quite far. Next slide. We've been doing these webinars since about 2011 through the Arizona Telemedicine Program, and we have brought to you nearly 200 very informative webinars. It is being sponsored, as I said, by the Arizona Department of Health and the Maricopa County Medical Society. Next slide. Now, these are just a few tips and hints, which hopefully you have memorized by now after a year and a half of doing webinars. But let me just go through them. As you join the webinar today, your microphone was muted. Please use the chat function of Zoom to ask any questions, and they will be answered at the end of the presentation. Any questions that we don't get to, we do have your contact information, and we will get those to you afterwards. It is being recorded, and you will be able to access it, as well as all of our previous webinars on our website. The URL is listed below there on the slide, and we will also post it in the chat. Next slide. Now, CME is being offered for this event. The University of Arizona College of Medicine Tucson designates this live activity for a maximum of 1 AMA PRA Category 1 credits, 1 credit, and physicians should claim only the credit commensurate with the extent of their participation in the activity. Next slide. Throughout this talk, the opinions expressed in this presentation and on the following slides are solely those of the presenter and not necessarily those of the organization sponsoring the webinar. The organizations do not guarantee the accuracy or reliability of the information provided herein. Next slide. Now, to request your certificate, whether it's CME or a non-CME, please complete the evaluation at the end of the survey. A link, Monkey Survey link, will be populated in a separate browser window, and there is required information that's required for a CME certificates to be processed. This URL will also be posted in the chat towards the end of this session. So next slide. It is my distinct pleasure to introduce today's webinar, HB 2454 and its impact on Arizona for healthcare professionals. My opinion is this is probably the most forward-looking and most comprehensive bill in the United States with respect to telemedicine. So Arizona, in my opinion, is far ahead of the curve than any other state, which we should be proud of. Our presenter is Christina Corriere. She serves as Governor Ducey's Senior Policy Advisor. In this position, she advises the governor on various issues and policies affecting healthcare at the state and national level, as well as on welfare, insurance, child safety, and health-related licensing boards. Prior to joining Governor Ducey's staff, she held positions including healthcare policy analyst at the Goldwater Institute, chief of staff for Councilman Sal DeCiccio, and vice president of the government and board relations for a national nonprofit. Hopefully the councilman is not on this talk, and I do apologize if he is for butchering your name. I'm Polish, not Italian. She holds a JD from Arizona State University, as well as a BS in political science and a BA in history. So without further ado, Christina.
Thank you so much, Doctor. And I guarantee Sal's not on this call, so you don't have to worry about his last name. Well, thank you so much for inviting me to be part of this discussion today. HB 2454, the telehealth omnibus, was one of the governor's priority bills for last session, and I had the pleasure of working on it from its inception to getting it across the finish line. We were blessed to have a wonderful sponsor in Regina Cobb, and the ability to work with stakeholders starting back early last fall to develop it and make sure the bill was what we needed it to be. But before we get to the bill itself, I want to talk about how we got there. This pandemic that we've been all dealing with for the last year and a half, has had many, many challenges for all of us to face, both in personal and professional life. I am an optimist by nature. So I always like to try to find the silver linings in everything. And I think there are silver linings even in this pandemic. And in the healthcare field, the two that I really look to are the new vaccine technology that we're seeing with mRNA vaccines. I think there's a lot of opportunity for the development of additional vaccinations for diseases that we haven't been able to effectively prevent already. So we're looking forward to seeing where that goes in future years. But the second is really telehealth. They say that necessity is the mother of invention. And even though necessity and the pandemic didn't invent telehealth, it certainly was responsible for accelerating its growth. So I wanted to share this graph that I had seen from McKinsey & Company. It took a look at telehealth comparing February 1st, 2020 to where we are now. And you'll see in March, those numbers just skyrocket. We had to overnight flip the switch from inside the doctor's office to telemedicine as an option for many people. Sometimes because that individual themselves might be sick and not wanting to expose others to their illness. Sometimes because they weren't wanting to expose themselves to somebody that might be sick in the doctor's office. So you can see just how telemedicine took off. That graph is nationwide, so I wanted to share some Arizona specific data. While I don't have data on commercial companies inside Arizona, that would be their own private data, we do have data from the Access program, and you can see it shows about the same thing. Prior to March 2020, about 10% of individuals on Access were receiving one or more telehealth services a month. That number is now at 31.4%, which is actually higher than what we're seeing in a lot of the studies. That may be influenced by the fact that we have a disproportionate number of rural folks with transportation difficulties, and people accessing the behavioral health system being particularly suited to telehealth. So in the early days of the pandemic, as that graph showed, there was a spike. We saw more than 32% of all doctors' visits taking place via telehealth. Since then, that's leveled out. Most specialties are between about 13 and 17% now. Certainly there are a few specialties that are lower than that. And then there's a few specialties such as psychiatry that are still at about that 50% level. As of April 2021, 84% of physicians across the country were offering some virtual visits, and 58% of them report viewing telehealth more favorably than they did during the pandemic. This is largely a result of people getting used to using something that was not used much prior to that. But I think it's also important to look at how the healthcare consumers are viewing telehealth. Prior to the pandemic, only 11% of healthcare consumers reported ever using telehealth. By the end of the pandemic, that number was well over 50%, and 40% of consumers in surveys have stated that they believe they will continue to use telehealth in some fashion going forward. The reasons for that vary. One is simply convenience. I think that's especially true of the younger generation that's used to getting things on demand and not having to wait. But you also have individuals who are living in rural communities who may have more difficulty accessing healthcare. You have individuals who may have transportation challenges. And then you have improved access to specialty care. So they may find it easier to get with a psychiatrist faster via telehealth than they would an in-person visit. So it's important to ask, how did that overnight pivot happen? Well, I think the number one reason is circumstances made it happen. It also happened at a time when technology was advanced enough to be able to support this, and a large number of people having access to broadband in their home. But I think government action is really the piece that facilitated this. So early in the pandemic, on March 24th, 2020, Governor Ducey had issued an executive order related to telehealth services. And it did a variety of things, including requiring payment parity for all services covered through telehealth, so that the doctors paid no differently, regardless of whether that service was in his office or done via telemedicine. It also made sure that the individual wasn't being charged more for a copay, so that there wasn't a barrier there. It expanded the number of provider types that were authorized by law to use telemedicine. It expanded the locations where telemedicine could happen. So a patient didn't have to go into a licensed medical space, but instead could do that from their own home. And it required access to cover telemedicine in the same way, at the same parity that we are doing with commercial insurance. That became very important. You know, one of the reasons most doctors had previously not made telehealth a large part of their practice was simply because they got paid a dramatically less amount for those services, regardless of the fact that simply providing the service to me via telehealth and to the next patient in person didn't actually reduce the cost of that doctor's office that they still need to keep. CMS also had to change its rules. Prior to the pandemic, Medicare did not cover many services via telehealth, especially outside of rural areas, and Access had to change their policies as well. So it was circumstances that required this, technology that helped make it possible, and government action that really helped to facilitate it. How can telehealth remain a tool going forward? So executive orders are great. They help us react in an emergency, as we saw in March of last year, but executive orders are not permanent. They will go away when the emergency concludes. So we had to ask, what was the most important piece? And we had a variety of discussions with all provider types throughout the summer and fall, and it really boiled down to one issue, and that was payment parity. The doctors would be happy to continue to offer telehealth, but they needed to be paid the same for those services. This really aligned with what we were seeing in national studies. One study that came out said that while 84% of physicians were offering virtual visits, 54% of them reported that they would not continue to offer virtual care if it was even at a 15% discounted rate. Again, it's because they're not going to be able to close their office or order less medical equipment or pay their staff any less because some number of their visits are virtual. So it became very clear that payment parity was really the key to allowing telehealth to remain a tool. And so that became one of the main pieces of HB 2454. So I like to describe this bill as the most comprehensive telehealth bill in the country. And I thank you, Elizabeth, for your comments at the beginning. It's really gratifying to have that validation of the same belief from folks outside of the ones that really put this bill together. I do want to say before I get into the meat of the bill that, you know, I don't think, and I don't think anybody thinks that telemedicine can or should replace in-person healthcare. It is a tool. It's something that doctors can use in circumstances where it's appropriate, but it never should be a complete replacement for that doctor-patient in-person relationship. And I don't think that's how most doctors view it or would think that it would become. As I said, there was a strong stakeholder process over many months, a sponsor with a healthcare background of her own, and really broad discussion, including folks from both parties. So the bill was able to pass with broad bipartisan support. In fact, so much support that it got the 3/4 vote required to have an emergency clause, which made it effective upon the governor's signature. It was supported by the entire healthcare community. You can see the list of folks who sign in for any bill. For this one, it was supported by doctors, nurses, hospitals, federally qualified healthcare centers, patients advocates, the universities. In fact, the only opponents that had signed in against the bill at any point were some of our insurers. So payment parity. Under the bill, this requires that insurance companies provide payment parity for all telehealth services that use audio-visual. It prohibits insurers from denying or limiting coverage for telehealth, except for procedures or services for which the weight of the evidence based on the recommendations of the Arizona Telehealth Advisory Committee determines are not appropriate. It separates out audio-only services and requires payment parity only for audio-only services that are specifically recommended by the Arizona Telehealth Advisory Committee. It's that they may be appropriately delivered through telehealth. So we had created the Telehealth Advisory Committee in this bill. It is made up of healthcare practitioners from across the state. There are approximately 30 to 35 appointees. Of those, 33 of them are healthcare practitioners, and I'm sorry, 32 of them. One is from a company that makes telehealth equipment, and 2 are representatives from the insurers. This committee has already begun its work. It is meeting at Access and being chaired by the Access Chief Medical Officer, Sarah Salick, and myself. The first report on the audio-only coverage is due December 2021. The report on audio-visual is due in June 2022. The committee will then meet at least annually to update those as new studies and evidence comes forward and adjustments can be made. We felt that it was important to let these decisions about what is appropriate to be done via telehealth be made by healthcare practitioners rather than dictated line by line by folks at the legislature who don't have that hands-on ability or that hands-on knowledge. So this committee really has a lot of expertise, and they're being given a broad grant of power to make those determinations about clinical appropriateness. If you are interested in more information about the Telehealth Advisory Committee, we'll be posting minutes of both the full committee as well as the subcommittee hearings and meetings that are going on right now. You're welcome to email me after if you would like more information or like to become involved in some way. So some more specifics on telehealth coverage rules. We did think that it was important to allow insurers to have reasonable requirements for documentation and fraud prevention, but they may not be onerous or unreasonable. And insurers may not use telehealth only providers to meet their network adequacy standards. So if they want to have telehealth only providers that are an option to people, that's fine. But again, since telehealth is simply a tool and people need to be able to have that option to go in person, we did not feel it was appropriate to have telehealth only providers counting toward the network adequacy standards. Another piece that was in the bill was to allow some telehealth across state lines. Arizona took action a few years ago in something that we call universal occupational licensing, which is that if a practitioner is licensed in one state and moves to the state of Arizona, if they are licensed in good standing in that other state, they are issued a license. It's a much more simple process than going through reciprocity. It has cut through delays and red tapes, and our boards have learned how to be able to do that. We modeled this off that, which is that if an out-of-state provider is licensed and in good standing in another state, they may register with the applicable board here in Arizona to be able to provide telehealth services here. There's some steps they have to go through, including proving that they have any required insurance policies, as well as a statutory agent here in Arizona. Registration is not required to provide telehealth in Arizona for a limited number of circumstances. The first is in consultation with a healthcare provider who is licensed in Arizona and who has ultimate authority over the diagnosis. So prior to this bill, a doctor could certainly consult with an out-of-state doctor about a diagnosis, but that out-of-state doctor was having the doctor-to-doctor relationship, and the patient didn't have the ability to necessarily be part of that conversation. In the patient advocacy stage that we are in right now, patients want to be part of that conversation, and we wanted to make sure that that was specifically allowed in the law. So if, for instance, Mayo Clinic wanted to bring in somebody from Rochester Mayo to consult both with the doctor and be able to speak with the patient, they would be able to do that under this without having to register. Another exception would be to provide specific aftercare related to a medical procedure delivered in another state. So in certain areas of our state, Mojave County, for instance, it may be quicker for people to get to a hospital in Las Vegas than a hospital in Phoenix. And so we see residents of Mojave County sometimes having their surgeries in Las Vegas rather than in Mojave County or in Phoenix for whatever reason. This would allow that doctor that had performed that procedure to be able to do that specific aftercare via telemedicine if they deemed that appropriate, and they would not need to register. And then finally, this is kind of to address the snowbird issue in Arizona, which is to say that a person who is a resident of another state and they have a primary care provider or a behavioral health provider located in their home state, they would be able to see that provider via telehealth. This issue also came up, interestingly, as we were discussing the bill. I was having a conversation with someone around the Capitol who had said that during the pandemic, she went over to California for a short vacation and had planned a telehealth visit with her behavioral health provider. When she signed on and the behavioral health provider asked how she was doing, she mentioned that she was in California, and the behavioral health provider's response was, "We have to hang up right now. You're in a different state and I'm not licensed there." That didn't make a lot of sense to us, and we didn't want somebody who came to visit here in Arizona not being able to contact their primary doctor, that person who has that relationship with them and knows their history, or be able to speak to their therapist if that is what they need. So that is the telehealth across state lines. I did want to address limitations. While HB 2454 is a great and very broad bill, the number of plans that it affects is more limited. So Arizona HB 2454 applies only to plans that are regulated by the state of Arizona's Department of Insurance and Financial Institutions, or the Arizona Workers' Comp System. The Department of Insurance and Financial Institutions largely regulates individual plans in the state of Arizona, as well as small group plans. Many large employers, however, the plans that they offer are self-funded plans, which are regulated under ERISA and the Department of Labor rather than the state. So for those very large group plans, there would need to be federal action to address telehealth within an ERISA plan. Medicare will need to go through rulemaking to determine how they are going to cover telemedicine going forward. In Medicaid, we have a few more options. There are waiver opportunities. So even if CMS does not decide to broadly allow telehealth services, the state of Arizona will go after those opportunities via a waiver if we need to. And then the other system that it doesn't apply to is the VA, which again requires federal action for changes that they make. So that is the presentation. I wanted to save a good amount of time for questions, and I'm happy to take any that you might have.
Great, thank you so much. That was a wonderful summary. So we do have some questions. Let me start out with one. We actually have quite a few. Let's see. It would be nice to see rehab professionals included at all on the slides or even mentioned. PT, OT, SLP, as we do quite a bit to keep the population healthy and avoiding hospitalizations. Is there room for a PT to be on this committee? I'm well connected with your state leaders.
Yes, PTs are included. They were included in the executive order to make sure that they were allowed to provide telehealth services. They are allowed under 2454 to provide and get payment parity as well. And I believe that there is a slot for PT providers, or for one PT provider on the committee. Unfortunately, I have this screen up right now, and I don't have the screen up that has the list of the committee membership. But if it is all right with you, Chris or Elizabeth, I can email you after the names of the folks on the committee, as well as the licensure type, so you can see which slots are available. I think we have one still to appoint. The individual that had applied and we had selected has now changed jobs and didn't have the time to serve. Okay. So we'll get awesome.
And what about occupational therapy and speech language pathologists?
Same thing, and they also have an appointee on the committee. As I said, we wanted to make sure that the committee was very broad. We have a couple general doctor spots, and then spots specific for a doctor that deals with pain, a doctor that deals with substance abuse. We have psychiatrists, psychologists, 2 advanced practice nurses, speech and hearing pathologists. It's, as I said, a broad committee, but we'll get you the details.
Awesome. That is very comprehensive. Does the bill modify informed consent requirements for telehealth in any way?
It does not modify informed consent requirements. It does say that a patient would not have to choose telemedicine, that if a patient wants a in-person, they couldn't be forced by their insurer to only take telehealth.
Right. With the new across state lines.
Oh, I should add one piece in there. Part of the reason for the fraud prevention efforts was wanting to make sure that the patient consented to the services. So there is patient consent in there. One issue that an insurer had related to us, and I want to start this by, I believe that almost all healthcare practitioners are good, ethical, responsible people. Unfortunately, in every profession, you have 1 or 2 people who take advantage of the situation, and they had seen where they had a specific doctor that decided to call through his entire patient rolls when COVID started, just to say, with this COVID out there, wanted to make sure you were feeling good, and the patient thought, well, how nice it was. My doctor called just to check in, and then found out that it was billed as an office visit, and that patient was also assessed a copay. And so the insurers are allowed to require a patient consent to the visit to address that issue.
But please verify that does not mean a separate sort of the same. It's not the same type of consent, informed consent, that you would give for participating in a study as a human subject. This is just your standard consent to be seen that any patient signs when they go in person to you know, they may not read it, but they get it and they sign it.
Correct.
So it doesn't have to be anything more than that, although some places obviously put in telemedicine language these days.
Yes.
Great. With the new across state lines provision, what impact does it have on medical licensure compact?
We don't believe that it has any impact on the medical licensure compact. If they wish to seek a full license, they are able to do that. They would not be able to open an on-the-ground practice unless they were fully licensed in Arizona, either through the compact or through the regular licensure process. So they could only do telemedicine through the registry. The bill also requires the applicable boards to do an annual report on the number of these registrants. So we'll start to get data for that in probably next year.
Right. So 2 questions on the prohibition on insurers using telehealth only providers to count towards their network adequacy. First question, does this mean that insurers may not require patients to see a psychiatrist at, for example, Amwell, and must instead allow patients to continue seeing their Arizona-based psychiatrist?
I would have to see the details of that, but this was getting at an issue with the Department of Insurance. So every year an insurer has to submit documents to prove that their network is adequate to see all of their patients that they cover in Arizona. So they have an appropriate number of oncologists, or an appropriate number of OBGYNs, or an appropriate number of psychiatrists. And so this is simply saying that for that measurement, those cannot be met by telemedicine only providers. Now, if a general practitioner in the state of Arizona did, say it's a pediatrician, and they offer both in-person as well as telemedicine, that doctor could be counted toward their network adequacy, but a telehealth only cannot. So
okay, so theoretically, if there's enough Arizona-based psychiatrists, the insurance company cannot say to the patient, in order to get reimbursed, I don't care if you have enough providers in Arizona, you have to see Amwell because that's the group that we recommend or prefer.
Well, again, I would have to get some more information on this. I don't know if Amwell is a group. It doesn't require them to expand their network. It's just not allowing them to use telehealth only to meet that standard.
Okay. Okay. So does telehealth only apply only to provider systems such as Amwell, or does it apply to individual providers who may only do telehealth but are part of a system that also offers in-person care?
So it applies to anyone who's telehealth only. They can be in their network. There's nothing wrong with them being in their network, being offered in their network. They just cannot be used to meet that network adequacy standard.
And I think you already answered this one in the affirmative, but let's just verify. Are therapy providers also covered under the bill and able to provide telehealth across state lines? Arizona is a participant in the Physical Therapy Licensure Compact.
Yes, every group that is covered by this law for payment parity is also covered by across state lines. So they would have to meet the requirements. They would have to be licensed and in good standing in one of the other states, and they would have to go through the registration process that will be laid out by that board. If they do that, though, they would be included.
Okay. Where is the list of healthcare professionals covered by the bill? Does telehealth across state lines apply if a healthcare provider is in another country if they still hold an Arizona license?
Well, if you hold an Arizona license, you would be able to practice in Arizona. That's,
Yeah, but can you live outside of Arizona and still do it?
This does not address across international lines or individuals who are licensed in other countries. And the first part of the question, I think, was where is the list of professions that are included? So bills are complicated, and there's unfortunately not a section that says it applies to the following professions. Instead, what it did was it took the same language and it pasted it in the DO statutes, it pasted it in the MD statutes, it pasted it in the nursing statutes, it pasted it in the psychiatry statutes. So you'd have to go through and individually look at those. I think it'd be really easy for us to pull together just a bullet point list that we can share with you of all the boards that it applies to. But essentially, it applies to all of the health boards.
Okay. And I guess in terms of the licensure, as long as somebody because there are, I guess, are there restrictions on where the provider can be? As long as they're licensed in Arizona, The provider does not have to be in Arizona. The provider, as long as because that could be, that's what a lot of these companies do. So I could be a provider, and as long as I'm licensed in Arizona, I could live in Connecticut and still
You're
provide
licensed in
services because
Arizona?
I'm licensed in Arizona.
Yes.
Right. It gets complicated though when it's international and that person is living in another country, even though they're licensed in Arizona.
Right. This does not address other countries. There was.
Gotcha. So what do you suggest that organizations or associations in Arizona can do to address telehealth across state lines? Because this critically does affect the practice for occupational therapists.
Can you clarify what they mean by how it affects them?
Mary, can you clarify, or can we unmute Mary?
Yes, I can unmute Mary. Okay. Why don't you go to the next one while I figure that
Yep. All right.
For
Is
her.
the Arizona state plan included in the bill?
The Arizona state plan is a self-funded ERISA plan, so it is not included in that bill. It would be regulated by the Department of Labor. That said, Arizona has options to be able to add it, and we have expanded our telehealth services and are paying at parity, but the bill does not apply to self-funded plans because of the ERISA law.
Okay. And Chris, just let me know when we have Mary ready.
We're good.
So we're good. We do? Okay, Mary, what was your
yes, hi, thank you for letting me speak. Twofold. First of all, with the volume of occupational therapists that are licensed outside of Arizona, well, I shouldn't say licensed, are living outside of Arizona that hold licenses within Arizona. My concern is twofold, is that yes, people can live everywhere within the United States and practice in Arizona, but is that helping or hurting occupational therapists, for instance, that live and practice in Arizona? And how does this telehealth across state lines, is that affecting or changing any of that relationship? So that's question number one. And number two is the across state lines reciprocal? So that if somebody lives in Arizona, where can they practice outside of Arizona without holding a specific license in those other states, or must they also hold it until the National Association for Occupational Therapy are part of that compact?
So it is not reciprocal in the same way that the universal licensing was not reciprocal, which meant the state of Arizona was going to say, if you move to Arizona, we'll give you a license. If an Arizona person moves to Texas, that's up to Texas. If they want to follow us, that's great, and we encourage that they do. And with the universal occupational licensing, we saw many states follow Arizona's lead on that, including some states that are much more blue than Arizona is. So it is not reciprocal, although we think that there are other states that will likely follow, just as they did in some of those previous bills. In terms of, is it good for the occupational therapist who lives in Arizona I think your question was probably to compete with those that are out of state. You know, in this provision, our focus was really on what's good for the patient. And if the patient wants to go to an occupational therapist who's in Arizona, that's great and wonderful, and that's the best choice for that patient. But if a patient wants to see someone who's outside of the state of Arizona via telehealth, then we wanted to be able to respect that choice as well. I think the example, you know, that I had given in committee was, if you had an orphan disease, or you had a specific cancer that maybe there's a nationally renowned expert in that cancer MD Anderson in Texas, you should be able to consult with that physician, and we want to respect the choice of patients and let them have that option.
Great, thank you.
Thank
So to be clear, if snowbirds have Medicare, then they cannot utilize their home state providers?
A snowbird will have two options under this law. They can see an Arizona provider. That is absolutely their choice. And I think many of them will continue to see somebody in person. But if they are, I'll just say Iowa, because that's where I'm from. If you had an individual who was from Iowa and came to Arizona, was maybe having an issue with a medication or ran out of a medication that they've historically taken, we thought it was best that they be able to see, you know, a general practitioner that is their family physician that they may have had for 20, 30, 40 years, who knows their history, their medical history, maybe prescribed them that medication, that they be able to see that general practitioner or their behavioral health provider. It's not broader than that for seeing your home state physician.
Perfect, thank you. What about the Indian Health Service? Where do they land when it comes to telehealth and coverage?
So that would be another limitation. I probably should have included that on the last one. The state has no regulatory authority over the Indian Health Service, which has caused a few challenges in the past. So when we were working on opioid data, for instance, I like to say we used to have two blind spots, and those blind spots were the VA and IHS, because we weren't able to get data from them to the same level and at the same frequency that we could get it from hospitals or insurance companies that we regulate here. But IHS rules would be set by the federal government, not by Arizona. That said, we do have a large amount of tribal members who are on Access. And while Access requires that tribal members be offered a fee-for-service plan, they can also opt into a managed care plan. And as I said, with Access, we are doing payment parity, and we'll continue to do that even if we need to seek waiver approval for that.
Awesome, great. With respect to the Ryan Haight Law and the bill, where are we with in-person visit requirements prior to televisit when controlled substances are involved? Is it still waived? You know?
It is still waived. However, there are specific provisions on out of state on that, because we don't want people coming in and just prescribing controlled substances.
Okay. How can a licensed primary care provider find out if they can provide telehealth services to their established patients who are out of state at the time of the telehealth visit? And I presume it's more in the context of vacation or this kind of the reverse snowbird question, rather than just permanently out of state.
Unfortunately, that's not something that the state would be able to regulate. So if you were, say, a pediatrician and your patient was in California going to Disneyland or something, the Arizona law wouldn't apply. You wouldn't get in trouble from Arizona law, but you would have to see what the California law is. So it's very complicated, and I think for the time being, it's probably going to be asking those questions to your patient of where are you physically located. But if your patient is physically located outside of Arizona, then Arizona law does not apply, and the law of whatever state or territory they happen to be in is the law that would apply.
I guess it gets complicated because a lot of patients will communicate through, for example, a patient portal contact and say, you know, I'm on vacation, blah, blah, blah. And they just get response through the patient portal, which some would consider telemedicine, some wouldn't. Or in the past, patients have just called their providers when they're on vacation and the providers say something. But once they put the word tele in front of it, things kind of change.
It also gets complicated with an insurance card too, because how do you know if you have a patient who has Blue Cross Blue Shield coverage, is that an individual Blue Cross Blue Shield coverage? So it's regulated by the Department of Insurance. So payment parity would apply because 2454 applies. Or I have a Blue Cross Blue Shield, but I'm employed by a large ERISA company. the ability to discern on those cards what law applies, because if it's self-funded or not self-funded, would be a challenge too, which is actually relates to a provision in another law that we put in that should help you all with this. We required that all new insurance cards this year and going forward have the words AZDFI on the card if it is a one that is regulated by the state. So you can have your administrative professionals look for those words on the card, and that would let you know that 2454 and payment parity applies. If those words aren't on there, then that person has an ERISA plan, and 2454 would not apply.
Okay, so that kind of answers the next question, which is, can we figure out which insurance plans are under the bill? Is there a list somewhere?
There's not. Every insurer, whether it's United or Blue Cross or Aetna, they offer both. So it's not as simple as looking at the logo. What you'll need to have your staff that's collecting insurance information or making copies of the card look for is AZDFI. And if it says AZDFI on the card, that means that's who regulates it, which means that this bill does apply.
Okay. Back to the question about the PT, OT, SLPs. What about audiologists?
Yes, they are included.
Good. Okay. Broad question. Is there a modifier? It might be too broad.
Yeah, can you get any more specific?
Yeah, Nancy, if you could type and see what modifier for what, but we'll kind of continue. For behavioral health providers that treat clients who come to Arizona for treatment from another state, I think we've kind of answered this. So can the providers continue to see those clients when they return to their home state? What are the limitations? I think we've covered that.
It would depend on the home state's law.
Right. Are there exceptions to the consent requirement if the patient is incapable of giving consent, and what documentation would be required to support that if so?
I would imagine that it would be the same documentation for providing consent for someone that is incapacitated and being seen in person. You'd have somebody else that would be able to provide that consent for them.
Okay. I guess sort of back to that, when the patient is out of state, what happens and what are the consequences? And I guess, what do you do if you set up, you have an existing patient, you set it up, you do the telemedicine, and then at the end of the telemedicine consult, the patient kind of says, oh, I'm on vacation in Maine, by the way, I'm off to go hiking. You're not licensed in that state, but you don't realize that the patient's there until the end of the visit. And maybe during the initial, when you asked, where are you, or are you in Arizona or whatever, maybe it was just confusion or you forgot to ask. What happens in those circumstances?
I mean, that would, first of all, I think it would be unlikely that someone would lodge a complaint with that state's medical board, but it would be a matter for that state's board to deal with. I certainly think that presenting the facts as they were and the defense of not knowing is something that I would share with that board, but it wouldn't be a matter for the Arizona board. If it became a matter at all, it would be with the board in the state where the services were delivered.
Okay, good. So if you're a fully licensed physician in, say, Tennessee, they just need to register with the state in order to provide telehealth consults in a patient facility?
They would have to register with the state, and that includes a check to make sure they are licensed and in good standing. They would have to prove they have the appropriate required insurance, and they would have to appoint a statutory agent in the state of Arizona.
Okay.
Now, if they did anything that would be a violation in the state of Arizona, if a physician here did it, then they can be removed from the registry and not permitted to be re-added to it.
Okay, and back to the list of providers. What about physician's assistants?
They are on there and they have a representative on the committee.
Gotcha. Let's see. Clarify, does the law apply to providers who are only providing care through telehealth with patients in Arizona, or are they required to also have an in-person practice?
They are not required to have an in-person practice in Arizona. They are simply required to have a license in good standing in another state. They cannot have a physical presence in Arizona without going through the regular license. So if you had somebody who, say, was a psychiatrist in New Mexico and had an office there, they could do the registry. Maybe they're going to provide some services to Greenlee County or Navajo County via telehealth. But if they wanted to open a satellite office in Arizona, they would have to go through the regular licensure process.
Gotcha. This is an interesting one. So what if you call the medications to a patient's preferred local pharmacy? So you're in the state, patient's usually in the state, you call it to their local pharmacy, but then the patient goes and fills that medication at an out-of-state location because they're on vacation. But they're at Walgreens, Walgreens looks it up, there's no consequences, right? They can do that.
I can't speak to the law in each other state. I don't think that I'm the appropriate person to answer that question.
Okay.
This
Yeah,
bill-
my understanding is
not-
that as long as it's filled in a legitimate one and it's sent into Walgreens, you know, in X, they can distribute it in any state at any Walgreens. That's my understanding. What are those words again? AZDFI. What does that stand for?
It stands for the AZ Arizona DIFI, sorry, AZ-DIFI is the Department of Insurance and Financial Institutions. It indicates that it is regulated by the Arizona Department of Insurance and Financial Institutions. And I don't remember which corner it has to be on, so let me pull that from the Department of Insurance's website, and we can send you the specifics on which corner that phrase has to be in, so that you can instruct folks in your office on exactly where to look, and they're not having to read all that teeny tiny print that is sometimes on an insurance card.
Sometimes, always.
So I'll get the exact location that it has to be, and then that will help guide your administrative staff.
Great, thank you. The modifier question was, they figured it out after listening. What kind of policies, procedures, et cetera, will be expected from provider organizations to reflect the changes?
I'm not sure I understand that question either.
Yeah. Paul, if you could clarify in the chat, that'd be great, but we'll move on to the next one. Are there any exceptions to prescribing controlled substances, psych meds, on an initial telehealth visit, or where can they find, and if there are, where can they find those exceptions?
Let me get an answer to that. We'll follow up with an email on that.
Okay. And I'm not sure this one, you can answer this one either, but what can providers do if a payer fails to reimburse appropriately, i.e. they reduce the reimbursement because the service was provided via telehealth as opposed to in-person?
If it is a plan that is regulated by the Arizona Department of Insurance and Financial Institutions, you can lodge a complaint with the Department of Insurance and Financial Institutions, which can investigate and enforce the law.
Excellent. Well, that kind of gets to the end of all our questions. That was like a marathon Q&A there, and you did an awesome job. Thank you.
If it's helpful,
so-
I can also provide the link and contact information for the Department of Insurance if folks have complaints.
Perfect. That's all great. So unless there are no further questions, and I don't see anything popping up in the chat, next slide. So to request your certificate, like we said at the beginning, you have to follow that little link there and fill out a few questions if you want your CME. So whether it's CME or non-CME, just complete the evaluation. And that follow that link and you'll be good. It was also put into the chat. And next slide. Again, this presentation has been brought to you by the Arizona Department of Health Services, Maricopa County Medical Society, and the Arizona Telemedicine Program. Please check our website for any upcoming events. And again, this will be it was recorded, and we will be posting it on our website as soon as it goes through that little process that converts it into something that everybody else can look at, which surprisingly doesn't take too long. And so we'll hopefully have that out there before the end of the week. And next slide. As always, we very greatly value your opinion. So please take a few minutes, and literally just a few, 2 minutes, if that, and complete an online survey. As you exit, you will be taken directly to the survey, and we truly, truly do appreciate your comments, your feedback, suggestions of topics, and so on. Again, Christina, thank you so very, very much for your incredibly informative talk on this topic, for spending all that time answering people's questions. And again, for helping Governor Ducey lead the country, literally, in making telemedicine available to the citizens of Arizona.
Thank you so much. It was a pleasure to join you.
Thank you so much.